Good afternoon, everyone. My name is Andrew Landrum, and I'm, of course, a student here at Maryville University, but not for much longer. So pleased to bring you my final presentation here on my scholarly project. Of course, my title, as you can see, is a multimedia pre-diabetic education program. And this program was a new program for our clinic and one that we did not have in place, and one that where we simply saw a need at our clinic for educating our pre-diabetics. My chairperson for this program was Dr. Amanda Flynn, and she has done a fantastic job in keeping me from getting too stressed out and just keeping me on track with this program. And it's been a pleasure to work with her as well. All right, a little bit about the title of the study here. Again, of course, we used evidence-based strategies, and we looked at a lot of multimedia technology and how it had been used in other research projects and other clinic settings to help make really lifestyle improvements, and then also to make improvements in A1C, which was our primary focus in this particular project, was to reduce A1Cs in the prediabetes patients that were identified. Again, continuing with a little introduction here, just prediabetes defined as hemoglobin A1C ranging from 5.7 to 6.4%. Most of us know that. It's just not something that we really look at. I think a lot of times we're dealing with diabetics in our clinics and in our different institutions, but for this particular project, we're looking at prediabetes and not diabetic patients. As you can see there, at least 86 million Americans have prediabetes. We are not even sure how many exactly have it, because so many of us are not even tested for prediabetes, and we're probably in that range of 5.7 to 6.4% and don't even know it. So that's kind of the scary part of that. And so another side project for this might be to look at identifying those with prediabetes and some additional screening in our clinics. But for this particular project, we're looking at how we can reduce the A1Cs in these patients that have been identified. It affects everybody, every race, every gender, every socioeconomic group. I currently work for a federally qualified health center, and so we deal with a lot of the lower socioeconomic levels. And in those levels, we see a lot of patients that struggle with compliance with medications and different things like that. But prediabetes, when we look at it as defining it, affects everyone. It affects us all, and it affects those of lower socioeconomic levels, those of higher socioeconomic levels. And so we're dealing with everybody. Another point there, it increases the risk for comorbidities such as hypertension, coronary artery disease, stroke, things like that. If you have prediabetes, then you're going to be dealing with some of those. The risk for those other comorbidities is definitely there. And then increased medical cost, of course. I mean, of course, anytime we have a particular diagnosis, a particular chronic illness, things like that, it's going to increase the medical cost. And so we need to keep that in mind as well. The purpose of the study, I think I've already mentioned this, but to determine if the use of multimedia-based education versus like your traditional method of, just giving maybe printouts of education for prediabetes, maybe a meeting with a diabetic educator, things like that. We focused on using multimedia education, such as text messages, such as applications on our phones, applications on our tablets, applications on our computers, things like that. So the purpose is to determine if the use of those things would encourage prediabetics to modify their lifestyle. And again, the end result is reduction in A1C levels. That's what we were primarily looking at. Some of the background here, just throughout the research and everything else, 1 out of every 3 adults has prediabetes. And when you think about that, that's kind of scary. When we look at that, 1 out of 3 of us are pre-diabetics. And the really scary thing about this is that we're walking around a lot of times when we don't even know it. Because if you think about it, when you get your screenings done and things like that with your doctor, maybe it's at your clinic that you practice at, many times we don't get an A1C level drawn. We don't look at that, at those glucose levels. Maybe your glucose level is good that day because you're fasting, but over a 3-month period, looking at an A1C, you might be in the pre-diabetic range. So 1 out of every 3 of us might have pre-diabetics, so pre-diabetes, so kind of scary. Insulin resistance is what leads to decreased ability to absorb the glucose. So, that's part of the background of what we're looking at here. And then lifestyle modifications, we believe, through the research that those lead to a decrease in A1C levels. And then last there is that, again, like I talked about in the previous slide, traditional methods versus multimedia education. And we've seen, and I'll talk a little bit about this more as we go through the presentation, but we've seen that there have been benefits to using multimedia education over those traditional methods. The problem statement here, despite identification of prediabetes, we looked at it, we looked at the clinic when we're looking to identify a problem here for the project, for this particular program. There was no program to educate prediabetics. We have a great program to educate our diabetics in the clinic that I serve in, but we don't have that for prediabetics. So we wanted to look at a way of identifying these prediabetic patients, looking at their A1C levels, and how do we go about educating them? And we're doing that through multimedia techniques. But this led to patients developing diabetes. When they go unidentified as pre-diabetics, we found that they were, 3 months later, they're in the diabetic range. Number 2 is that they're non-compliant with medications prescribed. Many times, maybe we put metformin on their med list and things like that. They're non-compliant with it. So they were non-compliant with meds and also lifestyle modifications. And then there's just a lack of resources here to assist these patients. So we tried to give them some resources here to move forward with, to try and get them some help here so we can reduce the A1C, get them out of that pre-diabetic level, and get their lifestyle changed at the same time. Some of our objectives and aims for this project, to develop, of course, a multimedia education program. Like I said, we didn't have one in the beginning, so it was important for us to develop a program. This was a pilot program. Number 2 is to identify patients with prediabetes. You can't have a program without identifying those patients. So we began looking at drawing A1C levels on pre-diabetic patients and on patients that we didn't know had prediabetes, but maybe maybe they were overweight, maybe they had hypertension, kind of all those signs. Number 3, to implement and review pre and post levels. That's the type of program that we looked at here, the type of project this was. It was a retrospective review, and so we did pre and post. And then to modify the lifestyle of the patients, which of course goes into the multimedia education that we're providing, to do lifestyle changes, to make changes in their life to where we can reduce those A1C levels. And then, like I said, to decrease the A1C levels. Those are the primary aims of our project, with the last one being reduction of A1C, which is what we measured. Of course, we did a literature review in this project. One of the most important parts, we found that multimedia education proved more effective than traditional methods in many of the studies that we looked at. Compliance increased with the use of multimedia technology. If you think about it, we only have just that little bit of time in our clinics to educate our patients, to talk to them about lifestyle changes, things like that. Many times they're non-compliant with coming back for maybe to meet with a diabetic nurse, things like that. But if we've got multimedia education on tap, we all have our phones. We all have things, just like this right here. We've got our phone right beside us here. And so we found that was an effective way to educate these patients. And then last, significance in identifying prediabetes early. We looked at early identification, and we saw that with the literature review. A little bit about the review of our literature. Prediabetes, again, is defined as an A1C level of 5.7 to 6.4%. That's how they defined it in the literature when we did our research, when we went through things, when we talked, or when we reviewed literature and things like that. Again, what we found over and over and over through literature review was that this often lies undetected in the populations. And it's just kind of, it is what it is. It's what we see with prediabetes, is that it's undetected. And then again, I've mentioned this before, but it's associated with long-term development of CAD, of obesity, hypertension, hyperlipidemia, stroke, different comorbidities that are there because of that prediabetes. But they all kind of work together against us. So that's a little bit about the review. Again, here's some more points here. The evidence supported a lack of education using, multimedia techniques such as apps, texting, tablet applications, different things like that in clinical practice. There just wasn't a lot of education that used this multimedia technology in many of our clinics around the United States, and definitely in the area where I work. We did not do that. It was a pilot program. The evidence supported improved patient outcomes in those using multimedia technology. And then lastly, there was a significant economic burden in those with prediabetes. And like I mentioned before, I work for a federally qualified health center, and we have to do everything we can to keep our patients compliant, just with medications prescribed and things like that. They really struggle to even know, what diabetes is, what diabetes entails, what they can do to help themselves. So we try to help them with diabetic education, and we do that day in and day out. But we didn't have that education to get them where they need to be before they develop diabetes. And so that was it. We looked at this project and we went, wow, what a great opportunity here to make a difference in some people's lives, especially at the lower socioeconomic levels where my career has led me. And so it was a way of serving, of giving back to the community and making a difference in patient lives. So I was glad to see that in the review of literature, and really glad that I chose this as a topic for my project for this program here at Maryville. A little bit about the design and methodology here. Again, I think I've mentioned this before, but it was a quantitative retrospective chart review. Most of us use some type of retrospective chart review with pre and post intervention design. That's what was used for this project. It was designed, again, to reduce A1C levels. And of course, we used guidelines from the ADA, American Diabetes Association, from the Centers for Disease Control and Prevention. We used guidelines from them to help us along the way. They have some guidelines out there for prediabetes. We used some of the diabetes prevention programs, things like that, to help with our design of the project. The setting, again, is a federally qualified health center in the southern part of the United States. Seeing primary care patients. There are about 3 providers, sometimes two to 3 providers per day in the clinic. The primary target population for this project was adults 18 to 65 years. Those were the people we looked at. Didn't look at anybody any younger, didn't look at anybody older than 65. So that was our primary age that we looked at. The patient volume for this clinic is a huge clinic. Exceeds 5,000 patients annually. The last few years, I personally have seen more than 7,000 patients a year myself. So it's actually probably exceeds 10,000. And so you'll see as we go throughout this presentation that we only got just a small percentage of the patients with this project. So that's definitely a limitation that we've seen this project, was the amount of people that we had that we were able to use for the time that we had to do the project. Some sources of data to determine those qualifying for the project. We de-identified data from the EMR of 50. Again, large clinic, large population of patients, but we only used 50 pre and post intervention patients, and that was collected by our clinic manager and our informatics manager. And then, of course, patients had to meet inclusion criteria such as The age that I mentioned, they had to be pre-diabetics, not diabetes, different things like that. So here's some of the variables that we collected. The patient's age. We looked at patient race. We looked at gender. We looked at, did this patient receive the intervention? Did they not receive the intervention? Did this patient receive education materials? Did they not? Did they receive medications? Some of them had medications on board already. We looked at their diagnosis. And of course, we looked at their A1C level, which was our primary focus. Some statistical tests and data analysis here. I just wanted to mention this because this is what we used in the project. Of course, we use Microsoft Excel to use for like encoding our data into different categories with the data collection sheet. SPSS was used mainly by the Maryville statistician to encode and run our tests for our project to see if we had significance in what we did with our interventions. And then I wanted to mention the type of test that we used, which was an upper tail Z test for difference in two proportions. And this was used for reporting of our results, our charts, our graphs, or different things like that show our data. Here's a couple of results just to kind of give you some idea of what we're dealing with. On the left, you have the gender. Most of our patients were female, but we did have 12 males. If you look at ethnicity, most of those it was about half and half Caucasian and African American in the project. And this is the main bar graph here that shows the results of our analysis. If you look on the left, you have pre-intervention, which A1Cs less than 5.7, which would have been out of the pre-diabetic range. There were 2. Everyone else was within that 5.8 to 6.4%, 6.5%. Post-intervention, we had 28 people that went from being in a pre-diabetic range to coming out of that pre-diabetic range. So we made a lot of progress in a small amount of time. And it's something that we were definitely proud of in our clinic. Obviously, I was proud of what we accomplished with the program in such a short amount of time. I think having a smaller amount of patients, with the number being 50, I think we were able to focus on them and get that multimedia education to them quickly and follow up with them quickly and things like that. And so it worked out really well as a project at a whole, and the results we were really, really proud of as a clinic. And of course I was. Here's another slide just showing some of the results. We had a p-value of less than 0.0001, which is less than the significance level of 0.05 that we usually strive for. And then the achieved power of the study was 1, which had a really considered high in strength. So we had a good significance here with going from 2 people that were in the pre-diabetic or below the pre-diabetic range to 28, after our intervention. So I thought that was great. A little bit of interpretation for our results. The statistical analysis determined that using the multimedia education, we were able to reduce A1C and improve lifestyle change, or you could reverse that and say we were able to improve lifestyle change and reduce A1C. And that was significant in this project, is teaching these patients, especially since most of those were lower socioeconomic levels, how to change their lifestyle, what to do to improve some things. And I thought we did a great job of that. The project budget, we estimated the budget was projected $832. This included some different expenses for research and printing, some the meeting venue, different travel expenses, things like that. Wanted to just mention that quickly. Our timeline required by IRB, clinic staff was conducted in May. Our clinic staff education on the project was conducted in May of 2022, and data was collected that summer between June and July for pre and September and October for post-intervention. So that was a little bit about our timeline. A little bit about our subjects. Of course, again, it's very important to keep this information confidential, to de-identify the patient information and to remove that from privacy. The data was always stored in aggregated form. It was always stored in a locked office and behind password protection as well. And then that will be deleted 1 year, following the project. So we want to make sure that we protect our human subjects and remember the ethical part of this project as well, and as with any project. So the strengths, it was a retrospective chart review, so it's ideal for evaluating effectiveness before and after. Simple. We all know how that works. We saw that with pre and post intervention, so we were very happy with what we did there. There are no time constraints. Data was de-identified, reduced bias, and all patients meeting criteria had equal opportunity to participate. So everybody was given that opportunity. Limitations, changes in clinical staff during the project. One of the things we noticed was that, at the beginning of the project, we had one set of nursing staff. During the project, we kind of switched out for different reasons. We had nurses going to school, things like that. So that kind of hurt. That was a little bit of a limitation. The small overall sample size was a limitation as well. Again, we just needed more time to be able to do that. And then it didn't include other important areas such as weight loss and BMI. So we could have included some other variables there. And there was a limited timeline between intervention and data collection. So just maybe more time is what we need. And hopefully we'll be able to continue this project in our clinic. In conclusion, the project concludes that multimedia education improved the lifestyle of these patients by decreasing the A1C levels in those identified with prediabetes. So the point is, the gist of it is here, our project was significant. We did a good job. We made some changes, and even if we hadn't, we put some programs in place here that are going to make a difference in people's lives, and we hope to continue that in our clinic. And then secondly, establishing this education results in the progress toward reducing development of diabetes, which is another side goal of this project. We didn't just want to reduce A1C levels. We want to prevent people from getting full-blown diabetes, where they have to be on insulin to control their A1C. We wanted to make a difference in their lives. And I hope that that's what we did. I hope that we tried to make lifestyle changes, not just, hey, let's go on a diet. Let's make some lifestyle changes here that are going to make a difference in your life. Future research recommendations. Again, we want to keep focusing on the interventional changes most successful at improving A1C levels. We want a larger sample size, and then we want to effectively educate our clinical staff, where we've got a program that even if you switch out clinical staff, you've still got that education for each and every person that comes in. They can just hit the ground running. Acknowledgements. This is maybe the most important slide of this project, in my opinion. I want to thank you to my chair, Dr. Amanda Flynn, for her guidance during this project. There were some times when I was stressed out. There were some times when I may have said some things to her that I just needed to say just to vent. And I know she's going to watch this, so I appreciate her and what she's done for me during this last couple of years or so. And she couldn't have done it without her. Thank you to all the Maryville faculty who helped guide the process. Many of you were our instructors for more than one class, and you know who you are. And if you happen to watch this, I appreciate you so much. And to my clinical leadership and staff at my clinic, thank you for allowing me to use the resources to complete the project. I couldn't have done it without you. And so many of them helped me throughout this. They were supportive of that. I just want to thank Maryville for being supportive and guiding us through this. And there were times when we thought we couldn't do it, but we were able to do it, and I'm glad that we did. And I just wish the best of luck to everyone. I hope you enjoyed this review of my clinical project. I hope you got something out of it. I hope you have some good comments about it when we post it in the discussion in a couple of weeks. Thank you for your time, and I wish you the best in your careers.